Howdy y'all, this is Jeff Jarvis and I want to talk to you about some ways to intubate safer. And I'm doing this really as part of a campaign that my new Canadian friend Jean Benoit has asked us to participate. He is launching a social media campaign called Safer Airways, and the idea behind that is to get a lot of people who are involved in intubation training and airway management training to put together some tips and tricks that might help people, well, intubate safer and manage airways safer. So, Gene, my Canadian friend and fellow Rush fanatic, this is for you. So, I want to go over a couple of just very brief tips about intubating with the King Vision video laryngoscope. So, this is the device, and this plug is not usually in here. We have this plug in just for video capture. There are two blades that come with the King Vision system. There is a channeled blade and a non-channeled blade. If you can see the channel running right here, this is the channeled blade. Now we use this blade exclusively. We don't use the non-channeled blade, and my tip is to always use the channeled blade. Now the reason for that is this is also a hyperacute blade. Both of the King Vision blades are hyperacute, and what that means is this uses a non-displacing technology. For example, it goes in and wraps around the airway structures, the mandible and the tongue, and has a camera at the end to give you a great view of the epiglottis and the vocal glottic opening. As opposed to direct laryngoscopy, which is a displacing technology where you have to lift up and away and move those structures out of the way. The benefit of using a hyperacute or non-displacing blade is that you can almost always get a really good view of the glottic structures. The problem is that because it is no longer a line of sight intubation, you can't always get the tube to go where you want it to. That's where the tube comes in. With some of these devices, with the non-channel blade, you have to use a rigid stylet. The channel allows you to avoid doing that. So we always use the channeled blade, and that's my tip. Number two is I recommend that you preload the tube into the channel so that now you can manipulate the blade and the tube with one hand. The next thing I recommend is don't push the tube too far beyond the opening of the channel, and the reason for that is if the tube is far down here, you lose some of the directional control you have that the channel gives you. So when you load the tube, make sure it doesn't go past the blade. The last thing on the blade I want to talk about is the use of a bougie. So a very wise person once said that you should approach all airways as though they're going to be difficult airways. Some people say that a bougie only needs to be used for a difficult airway. Well, that may be true, but we never know when they're going to be difficult and when they're not until we're actually in the airway. So I would recommend use your difficult airway tool for every intubation. So preload a bougie onto the ET tube that you have also preloaded. And I just don't extend the bougie past the end of the tube. So use a channeled blade and preload both the tube and the bougie. The next thing that I recommend is how to hold the device itself. The King Vision has a very nice handle on it. The problem is that it's a very nice handle and encourages people to hold it here. So even though this is a great handle, if you hold the device up here, one of the things we learned from trial and error is that you're very prone to inserting the blade too deeply. My recommendation is that you hold it very low on the blade. Now this does a couple of things. One, it removes your desire to use this as a tool that you have to use a lot of strength for. So you don't have a lot of leverage on the blade if you hold it low, and it turns out that's a good thing. This is not a device that you need to use a lot of strength with. This is not a brute force device. Video laryngoscopy, and actually direct laryngoscopy for that point, really should be something you use with finesse. So hold it low and light. Now I'm going to get to what happens when you go into low a little bit later. So the other problem, the next tip, is when you use this device, it's a very long tool. To get it into the mouth, you have to put it in at a pretty steep angle. And if you have a large chested patient or you have someone doing CPR on the patient, their hands or the patient's chest gets in the way and you have a difficult time getting it in at that angle. So what I recommend is decapitating the device, and I call it decapitating because this is the head, inserting the blade, and then, I'm not sure if this is a word, but recapitate the device. Put the head back on and then turn it on. So decapitate, insert the blade, and then recapitate. I mentioned that this is a non-displacing blade, so try to overcome your desire to use it as direct laryngoscopy or as a displacing technology. If you grab the device, go in and try to lift up and out like you would with DL, you're going to decrease the size or the quality of the view that you get. Plus you put an awful lot of pressure on the end of the blade, and the blade is just not designed for that. So low and light, and remember that the tip is wrapping around the tongue, not lifting the tongue out of the way. With DL, we spend a lot of time talking about inserting the blade off to the side and sweeping the tongue out of the way. With VL, you're using a wider blade. Insert the blade to the midline. Next, because one of the difficulties with video laryngoscopy, since your eyeball is essentially down here, is that if the patient has a spooged airway, if there's vomit or blood or whatever else they might have in there, and you just insert your camera right into the muck, you can foul your view, have to come out and start from scratch. So it's best to try to avoid that. So my recommendation is you put the blade in just a little, just put the tip in, keep it in midline, and then once you can see what's in the airway, gradually walk your way down the surface of the tongue until you get into the vallecula. So what you're trying to avoid is blindly putting the tip of the device into the vomit, and you're also trying to avoid the dependent surfaces in the airway where the mucus and blood and beer is going to go. So that stuff is going to fall down to the posterior surface of the airway. You want to make sure your camera stays anteriorly. So start with a midline insertion, and what you want to do is just walk down the tongue. Next, as soon as you put the blade in, if you see that there's mucus there, suction. You know it's going to be a problem if you put the camera into the muck. So suction as you go. Now, the one other additional nice thing about using a channeled blade, I mentioned that you can direct both the blade and the blade and the tube with one hand. Well, that leaves your other hand free to do something like suction with. Now, because there may be some really big chunks and you need a high volume suction, you have to make sure that your, I'm not quite sure what this little hole is, but carburetor, for lack of a better term, is closed. There's not a whole lot of benefit to leaving it open, so my recommendation would be grab a piece of tape and just tape over it. That just keeps it closed. The next thing that we all know but we have a tendency to do anyway is if you put this right up against soft tissue, you're likely to lose your ability to suction. So just be wary of where your tip is. All right, so to put this together, I'll go through a demonstration here and we'll be able to show you what we're seeing. Preload the tube, preload the bougie, and because of some recording issues, I'm not going to decapitate the head. Fortunately, we can get away with it here. Insert just the tip, do it in a midline fashion, begin suctioning, and keep the tip of the suction distal to the tip of the camera. The idea is that you're trying to keep the muck away from the camera lens. So aggressively suction your way down and walk the tip of the blade around the tongue. So keep the tip of the blade in contact with the tongue. You walk down until you see the epiglottis, and then you're in the vallecula. So that's called epiglottoscopy, and that is the key thing that you want to see before you intubate. It's part of what we call the view. So the view is that picture right there. You want to make sure that you can see the epiglottis at the top of the screen as well as the arytenoid cartilage and the cords. Now, you want to make sure that you can see the distal tip of the suction catheter, because if you can't, the suction catheter is actually proximal to the camera and you're likely to get spooged camera. So if you have someone who is continuously vomiting for whatever reason, or bleeding, or there's a continuous source of yuck coming up through the airway, just once you have worked your way down and can see the view, just go deep with your suction catheter, and you're actually using it now as a modified OG tube. Go deep, you can see your view, and then advance the tube in. Now, slide the tube in like that. So I'm going to back up a little bit and say, well, let's say that for whatever reason the tube wasn't going in. The next tip is to rotate the tube a little bit and have it pass. But if that doesn't work, use your bougie. Advance the bougie in, rotate your tube. See, that's where I needed to rotate the tube. Advance the bougie in, and then advance the ET tube over the bougie. And now you can disengage the tube from the channel. And you're good to go. A couple of troubleshooting things that are useful. We hear a lot, or we used to hear a lot before we really implemented some of these steps, is I got a great view of the cords, but I couldn't get the tube to pass. The reason for that is almost universally you're too deep. And that's one of the reasons that we say hold the tube or hold the blade low and light. So if you go in too deep, you're not likely to be able to see the epiglottis. You may have what looks like an incredible view of the cords, but if you can't see that epiglottis, the odds are that you're at the wrong angle and your tube is going to go straight into the esophagus. So if you get to a point where you say this is a great view but the tube is just not curving up, remind yourself that you're too deep, you don't have the view, back up a little bit. So I just heard someone on a podcast with Gene, as a matter of fact, say that a perfect DL view really gives you poor intubating conditions with VL. So if you see that perfect view without the epiglottis, you're probably too deep, back up a little bit. The next thing I want to point out is if you have any problems with the device at all, if you have a great view or you're getting a good camera image, if the camera comes loose, your image is going to freeze in place. The key solution to that is reset the camera or the head onto the blade and then reboot. Turn the camera on or off and then back on, and you're good to go. So let me just kind of go back over those. Number one is use their channeled blade. Number two, treat every intubation as though it's going to be a difficult intubation. Preload your tube, preload your bougie. Hold the blade low and light. Do not try to use the King Vision as a direct laryngoscope. Don't try to lift up and out. Remember, it's designed to rotate around the structures, not lift the structures. Start with a midline insertion. Put just the tip of the blade into the oropharynx so that you can see what kind of muck is lying in wait for you down in the oropharynx. Then walk the tip of the blade down and around the tongue, keeping the tip of the blade out of the posterior pharynx where that muck is. Suction early, often, and continuously. Make sure the tip of the suction catheter is distal or is always in view of the camera, because that way you know that it's distal to the camera. If there is a continuous source of fluid or muck, make sure that you just hub your suction catheter deep into the esophagus or deep into the oropharynx so that you're acting like an OG tube. Make sure that you get the view, and what I mean by that is make sure you have a great view of the epiglottis. I would recommend you don't try to pass the tube if you can't see that epiglottis, if you can't see that view. If the tube is going off to the side, rotate the tube a little bit to pass it through the cords. Remind yourself if you're getting a great view of the cords but the tube won't pass, you're probably too deep. Back up a little bit. Remember that you can, if you can't get the entire device into the oropharynx to make that turn, decapitate it, put the blade in, recapitate it, and if you ever have a problem with the view on the camera, reboot it. Turn it off, reset it, turn it back on. So those are our key tips to success with the King Vision video laryngoscope. Gene, I hope this works well for you, and I hope that this is useful. Thank y'all.